Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the hemorrhoids, internal hemorrhoids. Hemorrhoids are the varicose veins present in the anorectum, originating from the plexus formed by the radicals of the superior, middle and inferior rectal veins. The hemorrhoids may be external or internal. The external type is covered by the skin and the internal type are covered by mucous membrane. If the two types are associated, it is called intero-external hemorrhoids. Hemorrhoids may be a symptom of some other condition like carcinoma of rectum during pregnancy from straining on micturition upon a stricture of urethra in venous hypertension. Internal hemorrhoids. Internal hemorrhoids include intero-external hemorrhoids are exceedingly common. This condition is a varicosity of the internal rectal plexus, but because of the communication between the internal and external rectal plexus, if the former becomes varicose, the latter is liable to become involved. Causes of hemorrhoids: heredity, morphological, anatomical, exciting causes. Internal hemorrhoids in association with the terminal division of superior rectal are arranged in three groups: 3, 7 and 11 o'clock positions with the patient in lithotomy position. In between these there may be similar subsidiary hemorrhoids. Each principal hemorrhoid is divided into three parts: pedicle, internal hemorrhoid and external associated hemorrhoid. Pedicle. The pedicle is situated in the rectum just above the anorectal ring. As visible through a proctoscope, it is covered with a pale pink mucosa through which large tributaries of the superior rectal vein can be seen. Sometimes pulsating artery can be felt in this position. Internal hemorrhoids. It commences at the anorectal ring and ends at the dentate line. It is bright red or purple and covered by mucous membrane. External associated hemorrhoid. It lies between the dentate line and anal margin. It is covered by skin through which a blue vein can be seen. Unless fibrosis has occurred, it is present only in established cases. Entering the pedicle of each internal hemorrhoid is a terminal branch of superior rectal artery. Rarely there is a hemangiomatous condition of this artery called arterial pile. Clinical features: bleeding. Bleeding is the principal and earliest symptom. To start bleeding is a slight bright red and occurs during defecation. Splash in the pan. This condition may last for months or years. Hemorrhoids that prolapse sufficiently to be nipped by the anal sphincter for a moment at stool are called first degree hemorrhoids. The only symptom is the bleeding, which is the result of distension and subsequent rupture of the veins by sphincteric compression. Prolapse. Prolapse is a later symptom in the beginning and protrusion is minimal and occurs only at stool, and reduction is spontaneous. As time goes on, the hemorrhoids do not reduce themselves but have to be replaced digitally. These are called the second degree hemorrhoids. Still later prolapse occurs during the day apart from defecation when the patient is tired or exerts himself. Hemorrhoids that are permanently prolapsed are called third degree hemorrhoids. Now the hemorrhoids become a source of great discomfort and causes a feeling of heaviness in the rectum. Discharge. A mucoid discharge is a common accompaniment of prolapsed hemorrhoids. It contains mucus from the engorged mucous membrane, sometimes increased by leakage of ingested liquid paraffin. Pruritus. Pruritus will certainly follow the discharge. Pain is absent unless complications supervene. On inspection, there is no evidence of internal piles. In advanced cases, redundant folds of tags of skin can be seen in the position of one or more of the three primary hemorrhoids. If the patient strains, internal hemorrhoids may come into view transiently, or if they are of the third degree, they prolapse and remain prolapsed. Palpation. Internal piles can be palpated unless they are thrombosed. Very large internal piles are palpable. Proctoscopy. A proctoscope is passed to its full extent and the obturator is removed. The instrument is then slowly withdrawn. Just below anorectal ring, internal hemorrhoids, if present, will bulge into the lumen of the proctoscope. Complications. Profuse hemorrhage, strangulation. One or more of the internal hemorrhoids prolapse and gripped by the external sphincter. Further congestion follows as the venous return is impeded. It is common in second degree hemorrhoids. Thrombosis. The effect of hemorrhoids become dark purple or black and feel solid. Considerable edema of the anal margin accompanies thrombosis. Pain pass off and tenderness persists. Gangrene occurs when strangulation is sufficiently tight to constrict the arterial supply of the hemorrhoid. Fibrosis, suppuration, pylophlebitis or portal pyemia. Treatment of internal piles. Palliative treatment is recommended when the hemorrhoids are due to symptoms of some other condition. The bowels are regulated by isogel and if necessary a small dose of Sinocort at night. Lobafax or a cream of equal parts of zinc oxide and castor oil inserted into rectum from a collapsible tube fitted with a nozzle at night and before defecation. In case of inflamed and permanently prolapsed hemorrhoids with patulous anus, repeated dressings of glycerin acid tannic BP are more useful than the legion of remedies. Usually recommended. Surgery offers the only hope of permanent cure. Active treatment. This consists of injection of formal operation, each with a specific indication. Treatment should not be withheld as the patient is elderly. Injection treatment. It is indicated for first degree internal piles which bleed. Early second degree hemorrhoids are often cured by this method, but majority relapses. Technique. The patient should have an empty rectum, but no special pre-operation is necessary. A proctoscope is introduced and the hemorrhoids are displayed. The proctoscope is pushed further till the hemorrhoid has almost disappeared from the lumen and only its upper end is visible. The injection is made at this point above the main mass of each hemorrhoid into the submucosa at or just above the anorectal ring using Gabriel's syringes with the bowl of the needle directed towards the rectal wall. From 3 to 5 ml of 5% phenol in almond oil is injected. The injection should produce elevation and pallor of the mucosa. The solution spreads in the submucous upwards to the pedicle and downwards to the internal hemorrhoids and to secondary hemorrhoids if present, but is prevented by intermuscular septum from reaching the external hemorrhoids. There is slight transient bleeding from the point of puncture. The injection is painless and no after treatment is required. If there is one hemorrhoid, it can be cured by one injection. If all three are enlarged, each is injected at the same session. 3 sessions at 6 weekly intervals are required. If any is re-injected, sloughing may occur. Operation indications. The indications for hemorrhoidectomy are third degree hemorrhoids, failure of conservative treatment of second degree hemorrhoids, fibrosed hemorrhoids, intero-external hemorrhoids, when the external hemorrhoids is well defined, when arterial pulsation can be felt in the pedicle. Hemorrhoidectomy pre-operative treatment. 48 hours of pre-operative treatment is necessary and apparent a little more than the patient usually takes, or if none is habitually taken, 2 ml of Cascara evacuant is given on the evening 48 hours prior to the operation. Next morning, a small dose of effervescent saline is given before breakfast. On the evening before operation, a soap and water enema is administered and the anal region is shaved. On the morning of the operation, the rectum is washed out with the water by means of a funnel and a tube attached to a catheter. Ligation and excision. The patient is in the lithotomy position. The sphincter is widely stretched, a maneuver which greatly reduces post-operative pain. The internal piles are then prolapsed by traction on the skin tags or on the skin of the anal margin. Each hemorrhoid is dealt with as follows. The hemorrhoid is picked up with dissecting forceps and traction is exerted. Traction displays a longitudinal fold that is the pedicle above the hemorrhoid. Each pedicle is grasped with a fine pointed hemostat, as also is each external hemorrhoid or skin tag connected with each internal hemorrhoid. These pairs of hemostats when held out by the assistants form a triangle. The operator takes the left lateral pair of hemostats in the palm of his hand and places the extended forefinger in the anal canal to support the internal hemorrhoids. In this way, traction is applied to the skin of the anal margin. With scissors, a V-shaped cut is made, each limb of which is placed on either side of the skin holding hemostat. This cut traverses the skin and corrugator cutis ani. Exerting further traction, a little blunt dissection exposes the lower border of the internal sphincter. A traction ligature of number 3 chromic catgut is applied to the pedicle at this level. For each hemorrhoid, same procedure is followed. They are excised half-inch distal to the ligature, the ends of which are cut about half-inch from the knot. The stumps of the ligated hemorrhoids are returned to the rectum by tucking a piece of gauze into the anal canal with closed scissors. A margin of the skin wounds are trimmed so as not to leave overhanging edges. Bleeding subcutaneous arteries having been secured, the corners of 3 pieces of the petroleum jelly gauze are tucked into the anus so as to cover the area denuded of skin. A pad of gauze and wool and a firmly applied T-bandage complete the operation. Post-operative treatment. Twice daily baths are started from the first day. Liquid paraffin in the evening. The dressings float off in the bath. If not, they can be removed. The boils usually start on the 4th or 5th day. The baths and dry dressings like sanitary towels is best for this purpose. Hold in position by T-bandage, keep the area clean. On the 7th day, a finger is passed into the rectum to assess the degree of spasm. If there is a risk of stricture formation, a St. Mark's Hospital dilator is passed daily. The patient can leave the hospital on the 10th or 14th day when the risk of secondary hemorrhage has passed. In the latter stages, a dry dressing is applied during the day and a zinc and castor oil dressing at the night. The paraffin should be stopped after 10th day and the patient is encouraged to pass solid motion in order to dilate the anal canal. The wounds heal in 3 to 6 weeks. Post-operative complications. There may be early or late complications. Early complications are pain may be present and require immediate attention. Xylocaine jelly introduced through a fine nozzle into the rectum as necessary is required. Retention of urine. It is common in the male patients precipitated by the presence of a rectal tube or pack of bones. Before restoring catheterization, the patient is assisted to hot bath into which he may be able to void urine. If it is not successful, injection carbachol 1 ml IM is given. Reactionary hemorrhage. It is very common, may be concealed but will become evident on examining the rectum. Treatment. Morphine is given intravenously in suitable doses. If it is not stopped, shifted to the operation theatre. Bleeding point is secured by diathermy or underrunning with a ligature on a needle. If the bleeding point is not found, suspected areas are underrun in the same way. Late complications. Secondary hemorrhage. It is not common and If occurs, may occur on 8th day after operation. It is usually controlled by morphine. If not, con- uh, if not controlled and severe, an anesthetic should be given and a catgut stitch inserted to occlude the bleeding vessel. Anal stricture. This must be prevented by any cost. A rectal examination at the 10th day reveal if stricture is to be expected. In that case, under general anesthesia is dilate the anus to take 4 fingers. After that, daily dilatation will give good results. Anal fissure and submucous abscess may also occur. That's all about the internal piles, and in the next video I will discuss about some other disease. Thank you.